Okay, it's Medicosis Perfectionalis, where medicine makes perfect sense. We continue our physiology playlist to talk about clinically oriented physiology when it comes to muscles. This will not include a topic about electromyography because it was discussed in a previous video. Please watch my videos in this playlist in order. Who is the hero of contraction? Calcium, that's right. If you want to be more specific, it's the charged, ionized, free calcium. Calcium contraction, okay? There is a group of medication known as calcium channel blockers. What do you think they do? They block the calcium channels and therefore there is no contraction, therefore there will be relaxation. You have heard before that calcium channel blockers are divided into dihydropyridines, such as nifedipine, nimodipine, amlodipine, etc., and the non-dihydropyridines, such as verapamil deltiazem. And they told you that the dihydropyridines work more on the blood vessel and the non-dihydropyridines work more on the heart. But have you ever wondered why?
My professor told me, well, it's just the way it is.
Shut up. Of course there is a reason. There is a French proverb that says cherchez la femme, and there is a pharmacological rule that says cherchez la récepteur. And since all receptors are protein, this is more inclusive. Cherchez la protein. Do you remember when we talked about the sarcoplasmic reticulum? Yep. And its terminal cistern? Yep, that's the jail for the calcium. In order for calcium to leave the jail, you need two doors to open. The ryanodine receptor and the dihydropyridine calcium channel. Let's zoom in on this triad. There you go. A T-tubule, terminal cistern on this side, terminal cistern on the other side. And when the action potential comes in, what's going to happen? Calcium is going to be released from the jail and it's going to pass first through the ryanodine receptor and then through the L-type calcium channel dihydropyridine. And then calcium will go bind to troponin C, myosin will slide actin, #contraction. Calcium is the hero of contraction. When calcium is out, calcium is here, troponin C, actin slides over myosin. Calcium channels have many subtypes. We'll talk about just the subtypes when it comes to the alpha subunit of the calcium chain. You have the L-type, the T-type, the N-type, the P/Q type, or the R-type. L-type is everywhere. It's in your heart, skeletal muscles, smooth muscles, and neurons. T-type, SA node of the heart and the brain. N-type, presynaptic axon knobs. PQ type, Purkinje cell of the cerebellum, and you can find it in the presynaptic axon knobs. They say that Lambert-Eaton myasthenic syndrome has autoantibodies against the presynaptic calcium channels, which happen to be P/Q type. The L-type is more sensitive to the dihydropyridine calcium channel blockers, such as nifedipine. The T-type is less sensitive to nifedipine. N-type, PQ, R-type are insensitive to nifedipine. And that's why nifedipine works more on the blood vessels. But verapamil, which is a non-dihydropyridine calcium channel blocker, works more on the SA node and AV node of the heart. See, medicine makes so much sense once you understand what the flip you're talking about. Next, take a deep breath because we will switch topics. Do you remember this? That was a previous question. There's an autoimmune disease attacking the calcium channels here. There is another autoimmune disease attacking the nicotinic receptors of the acetylcholine here. The first disease is known as Lambert-Eaton myasthenic syndrome. The second disease is known as myasthenia gravis. Why did they call it gravis? Because they thought that it was caused by pregnancy, the gravid uterus. However, it's not caused by pregnancy at all. Here is Lambert-Eaton myasthenic syndrome. Here is myasthenia gravis. And this was the question of the previous video. Please pause. Let's talk about that. So here you have a 35-year-old male, complains of dyspnea, difficulty ambulating, tingling and numbness, blurry vision. Who do you think I am, Dr. House? Doc, I can't chew a cracker. Oh, dry mouth. Let's go. Sexual history is relevant for erectile dysfunction. What the flip is going on? I'm constipated. Work in a coal mine for 2 weeks. No one cares. The symptom that bothers him the most is difficulty breathing. Physical exam shows a warm, flushed face with no sweat. Decreased strength of the arms and thighs bilaterally. The table tilt test. This is for what? This is for orthostatic hypotension. You measure the blood pressure when lying down and you measure the blood pressure when the patient stands up. If the difference is significant, this is orthostatic hypotension. You order some PFTs and the results are as follows. FEV1 is low, FVC is low, FEV1-FVC ratio is high, TLC is low, vital capacity is low, residual volume is low, DLCO is normal. What's that? So, from FEV1 all the way until RV, From this, you know what? This is a restrictive lung disease.
How did you know, medicosis?
Because everything is low except the ratio is high. That's a restrictive lung disease. Now, the difficult question is it intrinsic restrictive lung disease or extrinsic restrictive lung disease? Well, what do you mean? By intrinsic, I mean the problem is in the lung tissue itself. By extrinsic, I mean something outside the lung, the diaphragm, the nerve supply of the diaphragm, the intercostal muscles, the brainstem, etc. How do I know that? Look at the DLCO. If the DLCO is normal, the lung is normal. So his problem is not in the lung, his problem in the surrounding structures. Have you figured what is that? This is Lambert-Eaton myasthenic syndrome. How did you know? Muscle weakness plus autonomic symptoms. How did you know muscle weakness? Here, dyspnea, difficulty breathing, the muscles are not moving. Difficulty ambulating, this is muscle weakness. Decreased strength of the arms and thighs bilaterally, this is proximal muscle weakness. And the autonomic symptoms, which include orthostatic hypotension, decreased sweating, blurry vision, erectile dysfunction. Which of the following is likely the underlying pathophysiology? That should be easy. It's B. Anti-voltage gated calcium channel antibodies on the presynaptic neuron. Second question.
Which of the following should be done for screening purposes?
And the answer is, since this is Lambert-Eaton, it's probably associated with small cell lung cancer, so the answer is CT scan of the chest.
What if this was myasthenia gravis?
You will go with A. Chest X-ray to check for thymoma or thymic hyperplasia. Question 3. Previous screening tests were negative, so he does not have small lung cancer. Awesome. Which of the following is the best management option? And the answer is C. Plasmapheresis, immunotherapy, and pyridostigmine. What the flip is pyridostigmine? So pyridostigmine, rivastigmine, neostigmine, all of this stuff is what? Acetylcholinesterase inhibitor. You're inhibiting the acetylcholinesterase. You're inhibiting the destroyer of the acetylcholine. When you inhibit the destroyer of the acetylcholine, what's going to happen to acetylcholine? It's going to accumulate because no one is breaking it down. More acetylcholine is going to bind to the receptor, causing more muscle contraction. Makes sense. When it comes to the muscarinic agonists, you have direct acting and indirect acting. The indirect acting are the acetylcholinesterase inhibitors, and they include idurofonium, physostigmine, galantamine, neostigmine, pyridostigmine, rivastigmine, donepezil, and tecrine. These are reversible, that's why we can use them as medications. The irreversible are not medications, these are poisons, war poisons for that matter. Idurofonium, neostigmine, pyridostigmine are used for myasthenia gravis and to a certain extent in Lambert-Eaton myasthenic syndrome. But galantamine, rivastigmine, donepezil, tecrine are for Alzheimer's dementia. You know why? Because in Alzheimer's you have low acetylcholine in the brain. If I inhibit the inhibitor of acetylcholine is going to increase and it's going to act more on your neurons, hopefully improving your memory or at least slowing down the deterioration. Let's compare between Lambert-Eaton myasthenic syndrome and myasthenia gravis. Both of them are autoimmune disease. Only Lambert-Eaton is paraneoplastic, secondary to small cell lung cancer, previously known as oat cell carcinoma. The antibodies, these are autoantibodies against presynaptic, these are against postsynaptic. Presynaptic what? Voltage-gated calcium channels. Postsynaptic what? Acetylcholine receptor, which is nicotinic sub-M. Muscle weakness improves with use, so the patient feels worse in the morning. As the day progresses, the patient feels better due to repetitive muscle use and contraction. But myasthenia is the exact opposite. Muscle weakness that worsens with use. The patient feels worse in the evening.
How come Lambert-Eaton improves the more you use your muscles?
It's probably because the more you use your muscles, the more action potential is generated in the presynaptic neuron, which will force as much calcium inwards as possible. Basically, your arm wrestling those autoantibodies. Lambert-Eaton involves the proximal limb muscles, so biceps, triceps, quadriceps, hamstrings, back muscles, but the extraocular muscles are rarely involved. It can happen, it's not very common. Myasthenia, extraocular muscles are very common. Distal muscles, so fingers, toes, and respiratory paralysis. That is serious. Autonomic symptoms are present in Lambert-Eaton, absent in myasthenia gravis. Why is this? I'll make a separate video about this in my playlist called Ever Wonder Why? Because that's a huge topic and it's very important. Okay, what do you mean by autonomic symptoms? Orthostatic hypotension, erectile dysfunction, dry mouth, constipation, decreased sweating. The deep tendon reflexes or the knee-jerk reactions, low in Lambert Eaton, intact in myasthenia gravis.
But hey, medicosis, how can I differentiate between a patient with Lambert Eaton and a patient with diabetic neuropathy? Because both of them have decreased deep tendon reflexes. Easy. Keep tapping the knee, tapping the knee, tapping the knee, tap the knee more, tap it again, tap it again, tap it again. If the patient starts to improve, that's Lambert Eaton. If the patient remains deteriorated, this is diabetes. Also remember, both diabetes and Lambert Eaton can have tingling and numbness. If you still can't figure it out, do an EMG. With repetitive contraction, Lambert Eaton is going to improve. Diabetic neuropathy is not going to improve. Who else is going to tell you about that? You woke professor? Shut up. What if I give idrophonium? Lambert Eaton is not going to improve a lot, but myasthenia is going to improve tremendously because the problem is in the acetylcholine receptor. Lambert Eaton associated with small cell lung cancer, myasthenia is associated with a thymoma or thymic hyperplasia. How to diagnose? EMG, and a challenge test. Basically, it's an idrophonium challenge test. Give idrophonium. If the patient improves instantaneously, this is myasthenia. The patient did not improve a lot, this is Lambert Eaton. How do I treat? Try to manage the underlying condition, in this case is lung cancer, and plasmapheresis, and you can also give pyristigmine. For myasthenia, give pyristigmine and also, please, perform thymectomy. Try to remove this thymic tumor. Pause and review. Take a deep breath because we will switch topics. Let's talk about dantrolene, the muscle relaxant. Oh, I think I've heard about this before.
Yes, do you remember neuroleptic malignant syndrome, which is one of the extrapyramidal symptoms caused by the dopamine receptor blockade, which can happen if you take an antipsychotic, especially a typical antipsychotic, such as haloperidol. It happens after weeks to months of taking the haloperidol. You get very high fever, catatonia, muscle stiffness, cardiac instability, stupor, rhabdomyolysis with myoglobin in my urine. What the flip should I do? Stop the haloperidol, no kidding, and give dantrolene with bromocriptine. Why dantrolene? Because it's a muscle relaxant. Do you remember another disease known as malignant hyperthermia, which was discussed in my anesthesiology playlist here on YouTube?
Yeah,
Basically, it's a side effect of succinylcholine. You get a triad of tachycardia, increased end tidal CO2, and hypothermia. How do I manage? Stop the freaking succinylcholine and give dantrolene. Dantrolene is a muscle relaxant. How does it work? It's a ryanodine receptor blocker. When you block the ryanodine, calcium will never be able to leave the prison. Calcium will stay in the prison and no muscle contraction will happen. #muscle relaxation. You can use dantrolene for neuroleptic malignant syndrome, secondary to an antipsychotic, or malignant hyperthermia, secondary to the stinking succinylcholine. If you like this video, you will love my autonomic pharmacology course where you can learn more about neostigmine, physostigmine, pyristigmine, ribostigmine, galantamine, tacrine, as well as epinephrine, norepinephrine, etc. It's on my website medicosisperfectionalis.com. You can also get my CNS pharmacology course where we discuss anti-epileptics, antidepressants, antipsychotics, anti-Parkinson's, stimulants, anesthetics, opiates, sedatives, and hypnotics. All kinds of Joe Rogan action. And also I have an utacoid pharmacology course about serotonin, histamine, cyclic AMP, treatment of peptic ulcer disease. And that's it for today. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Thank you for watching. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.